You're watching the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, what every woman needs to know about breast cancer treatment. With us, we have an expert on the topic. She is a board-certified radiation oncologist, Dr. Shukla. Dr. Shukla, welcome to the program.
Thank you for having me.
Now, before we get into today's topic, for people that don't know 21st Century Oncology, tell us a little bit about the company and also what your role is.
Sure. So 21st Century Oncology is a very large multi-specialty cancer specialist group. And so nationally and even internationally, they have approximately 750 doctors. And the reason why they're able to maintain so many different physicians is because they let us be our own doctor. And so for me, what does that mean? That means I can give patients the best personalized care possible. And how do I do that?
All right.
So the first thing I do is any new cancer diagnosis I see within 48 hours, and I take them through everything, meaning consultation. I review their images with them. I review the pathology with them. We discuss all the different options, and then we pick the appropriate treatment option for that patient. And then in terms of radiation, I'm involved with the CT planning. I'm involved with the treatment planning with my physicist, and then I carry out their treatment.
Okay.
In addition, most patients are only seen weekly during their radiation treatment, but I have an open door policy. I'll see my patients as much as possible.
I think it's important to mention that before we started, I said, what do you want women to know from this interview? Mm-hmm. And you said, and I'm paraphrasing slightly, but you said, I want women to know that if you've been diagnosed with breast cancer, you can choose your own doctor. You can make your own choices. Elaborate on what you mean by that.
Well, I think so many doctors are within networks. And when you get seen by an oncologist in that network, you stay within that network, which doesn't necessarily mean that you're getting the best care or the best physician for yourself. And so my goal or my kind of job is to try to educate you to pick a physician that's best suited for your personality and also has the best expertise in the area of treatment that you need, and so that you can have the best possible outcome.
But aren't they limited by insurance? I mean, a woman's been diagnosed with breast cancer. Mm-hmm. You're saying they have to go in network. So you're basically out of network, but it's covered.
I'm in network for most insurances.
Okay, and they don't know that?
They don't know that. Often when you're diagnosed with cancer, your primary care doctor will refer you to a medical oncologist or a specialist in cancer. And that referral is usually based on a prior relationship or on a in-network relationship. And so what happens is you often don't get the best cancer specialist, and you may not get the best person who suits your personality. And that's important because a cancer doctor's relationship is a long-term relationship. And so in order for you to feel comfortable and trust that doctor, you really need to know them.
21st Century Oncology, what is your role?
So for me, my role is to empower women to make their own choices. And how do I do that? Well, I've really spent a lot of time in the last 4 years getting to know all the different cancer specialists in Arizona. And I've tried to pick out the expert ones and get to know them personally as well. And so when my patients come to me, I give them a choice. These are a couple options that are good surgeons. These are a couple options of good medical oncologists. And so the patient can actually interview their physician that they like and choose a course of treatment that works for them. Also, I've also spent a lot of time learning the different technologies available. So 21st Century Oncology is fortunate in that they have comprehensive technology in terms of radiosurgery, brachytherapy, intensity modulated radiotherapy as well. However, there's even more specialized technology such as Gamma Knife, which is only available in one place in Arizona. And I'm a radiation oncologist that can go down there and take my patients down there. And so I've tried to bring comprehensive care to all my patients as well.
So let's begin with a woman has been diagnosed with breast cancer. Mm-hmm. Okay, so what are her options?
So there's so many different options, and it's so complicated. And what I like to do is bring my patients to what I have as a multidisciplinary tumor board. And there I have the presence of a medical oncologist, a breast surgeon, actually 2 breast surgeons come, myself, I have a radiologist, we have a pathologist, and we have plastic surgery presence. And so what we do is we spend the first 30 minutes or so reviewing all the patient's information, and then we bring the patient into the room, and the patient can ask us questions. And we get to know the patient a little bit better, and then we try to pick and choose what treatment option works for them. In terms of radiation, there's multiple options now. We used to live in an era where you could only do whole breast radiation, but that's changed. And so we have the conventional whole breast, which is delivered in 6 weeks, a shorter course, which is delivered in 3 weeks. We have something called accelerated partial breast irradiation, where you can have a catheter placed in your breast and have your treatment in 1 week. And then there's also intraoperative breast radiation, which is currently being studied.
Okay, now this team approach. So you meet with this team of medical oncologists, the surgeon, the radiation oncologist. You get together, discuss the case. The patient goes in there.
Yes.
So is it about a full hour?
It's a 2-hour conference.
And they're sitting in front of
the whole panel, yes.
the team. So that's not typically done?
No, it's not typically done. And the nice thing about it is we're all friends, so we all know each other. We all know how we work. We all work for different groups. We all donate our time, so there's no financial motivation.
And as far as insurance covers this type of team approach?
It covers, but that actual meeting that we have, it's done after hours, and it's not covered. But it's something that we enjoy doing, and we feel it's a service to the community.
And what do you call it? You call it a tumor board?
Yes.
And you meet with patients. So is that is that one of the main messages? Like you say, women need to know if you've been diagnosed with breast cancer. It makes sense that you'd want to meet with a team.
Right, exactly. Well, it gives you the opportunity to make your choice. And it also, you have us all there in front of a panel, and so you get to kind of know us too and where we're coming from.
So pros and cons obviously are discussed.
Yes.
So women watching this, and they're saying, well, this is not what I'm experiencing. Somebody's maybe 2 months into their diagnosis. And I think you told me on the phone, a lot of women do nothing.
Yes.
Because I guess they're overwhelmed with what should I do?
Right. And I mean, the problem is this, it is very overwhelming. It is scary. It's very confusing because you're not just seeing one doctor, you're seeing multiple doctors. Appointments get delayed, and so you really need somebody who's in charge. And so that's another reason why I want patients to make their own choice. And if you come to me first, at least I know a team of good oncologists. I can refer you, I can get you into all those physicians very quickly, and we can discuss your case collaboratively at our tumor board. So for example, there was a young 32-year-old woman who had a locally advanced breast cancer. She was initially discussed at our hospital tumor board, and we discussed doing delayed reconstruction, mostly because her tumor was so aggressive and we didn't want any complications. When meeting with her, she was very young. She had a young daughter, and for her to have a delayed reconstruction would mean delaying going on with her life and moving on with things. And so I ended up discussing her case with multiple experts in Houston and in New York. And then we discussed the case at our tumor board, and I actually sat down with the plastic surgeon there. We pulled up her individual images. I told him exactly what I had to do. He told me exactly what he had to do. And we figured out a way to work it out where he could place the implants in an area that I could still exit, my beam could still exit without causing any toxicity to her heart. And so we tried doing it, and it worked out wonderfully. And so she was able to have a direct implant. She finished her radiation, and then she was done with her treatment.
Okay, this multidisciplinary approach. So how many people potentially could be involved?
Well, in terms of physicians, we have anywhere from 6 to 8 physicians there. And we also, not just the ones that I mentioned, but sometimes with young patients, we'll bring in a fertility specialist. Sometimes we'll also bring in a geneticist as well. And then in terms of patients, we try to do 2 patients per week. And so, because it takes an hour, it really takes an hour for us, 30 minutes to kind of discuss it and review everything, and another 30 minutes for the patient.
So there's a lot of people, and we talked about this on the phone, they've been diagnosed.
Right.
And it takes a long time, 2 months maybe, with their schedule to get in for treatment.
Yes.
Or to see all the doctors, to see all the specialists.
Exactly. And so often they're not even given that option. So they'll just be referred to a breast surgeon, they'll have surgery, and then that limits the amount of radiation or what types of radiation I can offer them because, I didn't get to see them up front. And sometimes they'll get upfront chemo, but if you've had surgery already, then you're getting chemo after. And so it changes things.
But logically, it makes sense. Any woman, any man or woman, when you're diagnosed with cancer, if you're being given an opportunity to deal with a team and actually get to speak to 4 doctors right in front of you or more,
right,
or just one at a time, obviously everybody wants
the feedback,
to deal with a team.
The feedback is phenomenal that we get. The patients love it. And so we just want to get it out there more so that we can help more people with it.
And I guess the sad part of this whole thing is it's not like a referral business because it's an emergency.
Yes.
Somebody's diagnosed with breast cancer and now and it seems like, because we have a health show, but it
Yeah.
seems like the people come out of the woodwork, their friends, their family, everybody's giving them advice,
Right.
right?
Yes, and they're reading on the internet and they're getting so much information. It's information overload. And a lot of times it doesn't even pertain to that specific patient. And so it's important to have the right doctors. It's important to make your own choices.
So in this, because there's a lot of people, the medical oncologist, the surgeon, et cetera.
Yes.
How soon, if we're up to you, if you were to write the rules, right?
Right.
How soon should they see somebody like you or you?
I want to be seen up front. So at the time of diagnosis, I want to be seen either at the same time as the surgeon or within the next day or two.
What's the advantage to the patient?
Well, then they can see all the different types of radiation up front. And so if they really want to save their breast, we can talk about, all the different options and the way I can treat that breast. If they want to have accelerated partial breast, I can review with the surgeon if her cavity's technically in the right area or whatnot. And so we can make all those choices up front.
Okay, what's the biggest mistake you think women make when they've been diagnosed with breast cancer?
They rush to treatment. So it's kind of counterintuitive because I'm saying go quickly, but they will just see the surgeon and say, go ahead, have a mastectomy, have a lumpectomy. You have to get all the information before you make that decision. And so meet with everybody. Move quickly, but meet with everybody first and make an educated decision.
Do you feel like you're saving lives?
Yes.
Like
absolutely.
every day?
Absolutely. Well, I always say it's tough being an oncologist, but even the small things make a huge difference. And so every day I feel like I'm doing a lot. So for example, there was a 50-year-old woman who was treated with Hodgkin's disease with radiation 20, 30 years ago. And textbook definition is that she's not a candidate for breast conservation, meaning you can't save her breast. And she came to the tumor board for a second opinion. And looking at the location of her tumor, the stage of her tumor, we felt that we could save her breast and give her radiation safely. And lucky enough, the surgeon was good and did her job well, and I was able to get the catheter inside of her, and that resulted in minimal toxicity to her lung, minimal toxicity to her heart, and a lady who has long-term complications from traditional radiation. And so for her, it's a great outcome. It's just a simple thing that we can do, but it's made her very happy.
Now, we talked on the telephone, prior to you coming out here, and you said that cancer nowadays doesn't have to be a scary thing.
Right. It's changed so much. So we look at living with breast cancer as living with chronic disease, such as diabetes. And I always have this great story. When I was a resident in training, I seen this lady whose breast cancer had spread to her eyes. And when I went in to go see her, and I came out and I started presenting her case to my attending physician at the time, and he looked at me and said he treated her 10 years ago when her cancer spread to her bones. And so breast cancer patients, even at stage 4, can live a very, very long time. And so that's why it becomes more critical to make your choices about your physicians, because they're going to be in your life for a long time, and also your treatments, because the complications or the side effects of those treatments are going to have an impact on your life.
Okay, so everyone should get a second opinion?
You should, yes.
Or just some people should get a second opinion?
I think if you feel very, very comfortable with your physicians and your plan, well, then that's okay. Go ahead with that treatment. But it never hurts to get a second opinion.
So how does somebody get to see a specialist like you?
Okay, so the normal process is that their primary care or another physician, like a surgeon or a medical oncologist, makes that referral to me. However, I've tried to change that a little bit and open it up to the patients. And so if patients want to see me, they can contact my office, and we work with their primary care's office to get the referral. And so I don't want that holding you back. If you want to come see me, I'll figure out a way to make that happen for you.
So they could call 21st Century Oncology and say, I want to get a referral. So you just pick up the phone and call their doctor?
Yes.
Or they have to go visit their doctor?
No, I can call their doctor and make that happen for them.
Okay, good. And then they get to see you. Do people sometimes, now that you're on the program, I'm sure people are going to say, I want to speak to Dr. Shukla.
I hope so.
Is that right?
I hope so, yes.
You like this. That's a great response, by the way.
Yes.
Because it's one of those things that I know you told me a lot of things on the phone that you're not as passionate about right here. Maybe you're trying to be politically correct. But women are not getting all their options. They're getting diagnosed with breast cancer that could potentially kill them.
Right.
And they're not utilizing what's available to them.
Exactly.
Is that right?
It's totally true. And I mean, the issue is it's I mean, Arizona is kind of a different market, and where they don't have a big major medical center, and that was very different from Houston, where I trained, where we had MD Anderson, and it was out in the press on a regular basis. And so in Arizona, you have to do a little bit more work. You have to explore your options a little bit deeper. You have to go and meet people a little bit more. I had to do the same thing in order to form my team, and so it's just a little bit more work, but you have a better outcome.
So a woman's been diagnosed with breast cancer. She spoke to maybe a radiation oncologist, a medical oncologist. She spent time with a surgeon, but now she sees you being interviewed right here.
Yes.
Okay. Is it too late at some point? And I'm sure that they probably feel guilty. They say, I kind of like these people, but it makes sense because I'm not being exposed to a team approach.
Right. I mean,
what do you say to them? Because they are going to feel uncomfortable making a switch.
Some people do feel uncomfortable, but you have to kind of figure out a group of doctors that work well with each other, because communication is critical. So I have to know if your blood counts are low. I have to know all those little things, and so the physicians do have to know that. None of us get our feelings hurt. We understand that everybody's their own person. Everyone needs to make their own choices. And so, yes, I've had patients come see me and want to go to another radiation oncologist, or I've seen patients of other radiation oncologists who wanted to stay with me. So again, it's a personal choice. Most of us respect that. We're not going to take it personally. And most of us respect you for making your own choices.
Because you're not actually doing the procedures. Is that correct? Or you're doing some of the procedures?
I don't actually carry out the procedure.
So you're like a consultant in this role?
Yes. So what I do as a radiation oncologist is I'm trained in radiation, and I'm also trained in oncology. And so when I see the patient, I do all the planning, all the physics, all that work. I approve everything, and then the actual treatment is carried out by a therapist. But that therapist is under my direction. I check all the imaging, I check all the placement setup, and they actually just press the button and do that kind of work of it. But everything is under my direction.
Now, I have lots of questions about what you're doing with brain tumors. I guess you're the only center with a gamma knife, or using a gamma knife in Arizona. Is that right?
That's correct.
Okay. So before we move on to brain tumors and what people need to know, final message to women that have been diagnosed with breast cancer.
Okay. Well, I can't stress enough how important it is to have a multidisciplinary team, meaning being able to meet with your medical oncologist, your radiation oncologist, your surgeon, your plastic surgeon, all at one time to discuss your treatment. It's so critical for you to having the best outcome and the best quality of life. And so really, we're the only team that offers that quick approach in Arizona.
Okay, moving on to the second part of this interview, which is about brain tumors. What are you doing that's unique in your center?
Brain tumors have always been a special interest for me. I trained in Texas with one of the best brain tumor specialists in the country, and then I went on to do specialized training in Germany at one of the top centers in the world, and then I came back, and I'm fortunate enough where I live, where we have the Barrow Neurological Institute, which is the premier institute in the world for brain tumors, and they have a very specialized equipment called Gamma Knife, and the reason why this equipment is so important is because the therapy is so precise, and so it spares normal brain tissue beyond any other piece of technology that exists right now. And so for me, working with the neurosurgeons closely, I'm able to bring my patients to work with a Barrow neurosurgeon to offer them precise therapy for their brain tumors. And this isn't just important for primary brain tumors, but it's critically important in breast cancer patients who get brain mets, because they live a long time, like I said. And if you live a long time, sparing normal brain tissue becomes critical.
So this is when the breast cancer spreads to the brain?
Yes.
Okay. Now, there are a number of ways when somebody has a brain tumor.
Yes.
And what are the treatment options?
So,
and how is Gamma Knife clearly different than?
So when you have a brain tumor, you get something called radiosurgery. Radiosurgery can be delivered by a LINAC-based, which is something that's man-made radiation, and that's how we treat most brain tumors. Most breast tumors are all treated.
How is it administered?
It's external beam, so you come in, you get a mask made for you, and you lay on a table, and it's delivered to you, okay? Gamma Knife is different, and that is an actual cobalt source. So it's an actual radiation source that is being used and shaped to treat that tumor. And because it's a cobalt source, it's so precise. Man-made radiation is never going to be as precise as an actual source. And so because it's so precise, a neurosurgeon actually has to use an immobilized head frame to keep you in the same position, because we can't have you move at all.
So this laser beam, is it like a laser beam?
It is similar to...
And it's hitting the tumor.
Yes.
And kind of sparing the surrounding tissue.
Right. Hence radiosurgery, meaning it's so precise it cuts like a knife.
All right. Now, is the experts in your industry with brain tumors?
Yes.
Because if you're the only center that you're using the gamma knife there, is the gamma knife, by the experts or in the literature, a better treatment option?
Yes, it is the most precise treatment option that we have for brain tumors. And so any institution...
And nobody could argue with that?
Nobody can argue with that.
Then why aren't they all doing it that way?
Because there's different motivations, and sometimes we used to think that, we used to treat brain metastases with whole brain radiation. So if we're radiating the whole brain anyway, what's the problem with radiating a little bit extra? But the issue with radiating a little bit extra with such a high dose is it increases your risk for radiation necrosis. And it's becoming more and more critical when patients are living longer and longer. And so 10 years ago, brain mets didn't live as long as they do now. Even patients.
What's a brain met?
So that is when a cancer spreads to your brain. So it could be a lung cancer, it could be a breast cancer, it could be, those are the most common ones. And then other ones is some of the GI tumors, such as stomach and whatnot. They can go, but they're a lot less common. So
the experts would agree, if they were sitting here on a panel, that yes, what she's saying about gamma knife, the gamma knife is better than regular radiosurgery.
Well, I wouldn't say that. So radiosurgery with a cyber knife, radiosurgery LINAC-based, is just as good in terms of outcome. So you're not going to live longer because you got gamma knife. But where gamma knife is stronger and where it's better is that there is less toxicity because there's less normal brain being treated. And so that becomes critical when you're going to live a long time and you potentially need retreatment or that you want to avoid a potential complication.
Now, when we're talking about less downtime, that means less recovery in between treatments? The patients are feeling better sooner? The patients are thinking clearer sooner? Quantify it a little bit.
Meaning that in terms of, you won't necessarily feel a difference because you don't notice anything, but as a radiation oncologist, you're less likely to get a complication, meaning, your chances of radiation brain necrosis rates are way lower with the gamma knife than they are with LINAC-based, because LINAC-based is not as precise. And so you don't necessarily notice anything, but your rate of complication is lower.
Okay, I got it. So less side effects, potential side effects.
Yes, less potential
with
side
gamma knife. So you're a big fan of gamma knife?
Yes.
Okay, people have a lot of, I'm sure, fears of toxicity.
Yes, especially to the brain.
So tell me about this.
And so that's...
What do you want people to know about that in particular?
Well, it's more and more, so in cancer patients, the traditional thought was, well, there may be small cells of cancer elsewhere in the brain. And so if a little bit of normal extra brain tissue got treated, it's okay. But with the recent data, there's more and more evidence that's showing less toxicity. So meaning more precise, more high-dose radiation, radiosurgery is actually showing better survival outcomes in cancer patients, not just breast, but also in lung cancer patients. So in sick patients that we didn't think would live very long, they're also living longer from this therapy. And so why get gamma knife? Gamma knife is because it's less toxicity. And so if you need additional radiation to your brain 6 months down the road, well, yes, I've spared all your normal brain, where if I had to do a LINAC-based radiosurgery, I'm usually using a little bit of margin because it's not as precise.
And that affects?
It can cause radiation necrosis, it can cause other complications, and it also makes it technically a little bit more challenging if you have to go back and re-irradiate.
So now your role, okay, so if somebody has a brain tumor, okay, I guess they could live several years.
Yes.
10
yes.
plus years in certain cases,
yes.
right?
Yes.
Or even longer.
Right.
And they're already getting treatment elsewhere. And let's say that they're hearing this gamma knife maybe for the first time, or maybe it was lightly covered in the past. They could come in for a free consultation,
yes.
or it's covered by insurance.
Yes, yes.
And what do you want them to know?
So what I do is I look at the size of their tumor, we review all their prior treatments, and then I will review their case with a neurosurgeon. We discuss all these cases again in a tumor board with multiple neurosurgeons, radiologists, and we all discuss their case. And if we deem that they are a good candidate, it's a day procedure. So they'll drive down to the Barrow Neurological Institute. They will.
Are you there?
I am
on
there
that
for
day?
the.
Okay.
I'm there for the whole procedure. They will have the head frame placed. They will go for an MRI. We'll fuse that MRI with their planning radiation, and then the neurosurgeon and I sit down and we plan the therapy together, and then once we're happy with how everything works out, we deliver the treatment. The treatment itself is about an hour and a half, and then the head frame is removed and they go home.
Are there patients that don't know about Gamma Knife,
A lot of patients don't
that
know.
have brain tumors?
Yes.
Because it seems like if you get a brain tumor, you're going to search everywhere
Right.
on what all the treatments are.
Right. Again, though, your biggest source of information is your oncologist. And so if your oncologist works in an area and works in a network that doesn't have Gamma Knife, but they have a LINAC-based radiosurgery, you're often being sent there.
So they don't poo-poo Gamma Knife. They
No.
just maybe don't bring it up.
Yeah, they keep it in there.
Really?
Because it's radiosurgery, right? And it just depends on their mindset and whatnot. And a lot of radiation oncologists are not trained on Gamma Knife, and so they're just not experienced with the technology. And so you really have to be in a center where there's a lot of neurosurgery support to do such a thing. So almost every major center of excellence for neurosurgery has a Gamma Knife. So MD Anderson in Houston has a Gamma Knife. University of Pennsylvania has a Gamma Knife. University of Pittsburgh has a Gamma Knife. University of Southern California. So all the big major institutions where they have major neurosurgery programs and they treat a lot of brain tumors have Gamma Knives.
So ask about the Gamma Knife.
Exactly.
And is there any misinformation out there about Gamma Knife?
Some people like to have the frameless Gamma Knife so that you have to be immobilized with a head frame, which means 2 pins here, 2 pins here. But it's not invasive.
You could get sedation
You
if you had to?
You can get sedation, and we sedate most of our patients, so they don't even know. And so it's not invasive. It's just minimal to keep the head from moving. That's a little bit different than radiosurgery, where you just have a mask made, but that mask has a little mobilization, and so you're having 2 to 3 millimeters of margin, which means 2 to 3 millimeters more normal brain tissue being treated. So.
All right, now we are out of time, and I know 21st Century Oncology is big company across the country, but they can actually call and ask for you.
Yes.
I want Dr. Shukla.
Right.
Right?
Yes.
And so you have these tumor boards. You also meet every other week for that. Is that just for the breast cancer, or is that for both?
For the breast cancer. So for the Gamma Knife is a weekly meeting.
Okay, good.
So I can bring patients in every week, and that's more important because brain tumors need to be treated quicker.
And this multidisciplinary approach is not offered everywhere?
No.
Really?
No, especially in the community, it's not offered. And so you really have to seek out a physician or seek out an institution where they're offering such type of care.
And insurance covers this.
Insurance covers
So why
it.
not? Why not
Yes.
see somebody? So you're kind of like the quarterback, or you're the facilitator, or you kind of manage their care,
Right.
right? Okay, good.
Exactly.
We're out of time. I want to thank you so much for coming on the program.
Thank you so much for having me. It's a pleasure.
You've been watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.